All right, Kavita, I'm going to go one more time. So tell me about one-sided risk versus two-sided risk.
Right.
And if we're going to be, if the practices involved are going to be facing two-sided risk, were they not already in one-sided risk? And where is the risk in one-sided risk?
So right now, just to make sure everyone understands what one versus two-sided risk, everyone in the model up front is in an upside only, meaning nobody has to, quote, pay the government back if they actually spend more than what the CMS thought that they, quote, should be spending on total cost of care in cancer. So that's what kind of up and downside or two-sided risk is. As of this year, they have to actually, if you have not made in any of the performance periods, and just to make it completely simplistic, you don't have to have saved money all throughout the first 2 years. You just had to have saved money during one particular period of time in the 2 years, and then you can still stay in the upside risk for the entire model.
Why is it risk if it's upside? Risk is not upside.
So it's, one could argue, you're right, but I don't think that we're, with the volume of patients on Medicare who have cancer, to actually tell these practices from the get-go, I don't think it's actually fair to say you have to take downside financial risk, and I'll tell you why. This is the first time any physicians have received any data about their performance. And remind you that as most oncologists like to think they are the masters of all care when a patient has cancer, patients with cancer also have depression, diabetes, heart failure, and all these other problems that they happen to go to see a bunch of other doctors for. But this is a total cost of care model, all of those costs inclusive. So I actually don't think it would have been fair to give people true financial risk the way an actuary or an insurance company would think about risk, to be perfectly honest.
Oh, I totally agree, but it's
So
just not the way I understood everything that was coming out of CMS 3 years ago to be reading.
Well, you know, let me just add, I say the practices have gone at risk regardless, because they've had to make these investments in people and infrastructure, systems and things like that, and they're looking and saying, well, what happens if this goes away? What do I do? Do I fire people? I mean, what exactly happens? What do I do with the systems? So there's the risk that even though they weren't going at risk, as Kavita talked about, in terms of it was only one-sided risk, there are practices now that are not only facing that, what happens, but they're facing that I either have to drop out of this or I have to assume two-sided risk. Now, what's interesting is if you haven't done positively in one of these, or what we call in the black, performed in the black in one of these 3 performance periods, and you basically have to go at risk, that's crazy. It's like going to the casino and rolling the dice and putting your practice on the line. I mean, they are the least, those practices, those facilities are the least likely, or they're in the worst position, I should say, in terms of assuming two-sided risk.
Right, so they would not go forward.
They would not go forward.
You would drop out of the model if you were, I mean, that's exactly the conversation. So about a little over a third of the practices, maybe a little more, have saved money or would be able to, you know, stay in one-sided risk, which means that about half or a little more than half of these oncology care model practices are going to be asked to go into two-sided risk. And to Ted's point, these are the very people who actually can't do it. And by the way, just to kind of go to what the other Medicare models have done, this is exactly why the ACOs now have this in-between concept. They have what's called track 1.5, because there was really, it's the exact same thing that happened in primary care, Bruce. There were not enough takers to go to full financial risk in primary care, so they had to create an in-between. And that's kind of what we're seeing in oncology.
So despite the fact that many practices may drop out, I think many were surprised by the number that chose to participate, or at least the size and scale or scope, because we had 196 practices, but they weren't just, it wasn't 196 doctors. It represented close to 50% of the Medicare population under treatment.
But it was interesting. There were double that number, over double that number, that actually submitted LOIs that said we were interested. So what was interesting, it got down to, you know, 200 and low 200s. Then you had some dropped out, and it's roughly around 190 or so. But it's a fairly big population. And when you talk about certain practices like Florida Cancer Specialists, I think they have 9% of all of the patients actually. So you have a big contingent of Medicare patients that are in the OCM.
And academic institutions.
Right.
I mean, it's
and insurers.
And insurers, right.
And insurers.
Right.